Welcome to EliteCare Surgical Specialists. I'm Dr. Zahiri, or Dr. Z as most of my patients know me. Today I'm following up with you about a recent case that we discussed. A young lady who came and saw us, this young lady who delivered 5 beautiful babies and developed abdominal wall bulging. Since our last video, we've had a chance to take her to surgery and perform a robotic abdominal wall reconstruction. I wanted to follow up with you to show you some of the changes that we see within about a week after surgery, and also highlight the diagnostic process, including the CT scan of the abdomen and pelvis. So without further ado, this is the CT scan of the patient. The way we want to read a CT scan, if you can imagine the patient's laying on their back with the head of the patient going into the screen while their legs are coming out towards us. So essentially they're laying flat. This is the patient's back. This is the patient's chest wall. This is her right lung. This is her left lung. That's her heart. And we're basically starting from the level of the chest wall and working our way down towards the pelvis. So as we come down, we're now kind of gone from the chest area, looking at the point, the junction between the left rectus abdominal muscle and right rectus abdominal muscles. And the key to note here is the edges are very close together. There's a very minimal separation there in between. And I would say this would be about a normal size separation, but we will see this kind of get more exaggerated as we move from kind of the upper abdominal wall towards the pelvis. Keep your eyes over here on the separation between the left rectus muscle and the right rectus muscles. We now notice that the separation between those medial edges is even more pronounced. So as we come down further towards the pelvis, the size of the rectus, again on the left side, is about 9 centimeters, and usually the right side will be about the same. Why is this important? We measure this because it helps us to plan the surgery, specifically the approach, the positioning of the trocars. And so that is why for every abdominal wall reconstruction, we always want a CT scan of the abdomen and pelvis before surgery, so we can look at the anatomy of the abdominal wall. How big are these muscles and where are the defects located? This helps us to kind of prepare a mental picture and a mental image of the surgery before we ever step into the operating room. As we move further down, again, continue to measure that separation between the medial edges of the muscle. Again, this is the right rectus muscle, that's the left rectus muscle, and there's about almost 5.5 centimeters of separation here between the right and left. Now, we're still not near the navel area where the separation is most pronounced, but we're looking at the anatomy as we're coming down to determine how much of the abdominal wall is involved with this diastasis recti. And it seems like most of the upper abdomen really is involved from the time that we just get just below the chest wall area. When we get to the belly button area, this is kind of this divot over here, which is the belly button. We notice that the separation between the right rectus muscle and left rectus muscle, again, that's the edge, is most pronounced, 7 centimeters wide. Plus that there is a gap, peri-umbilical hernia. As we scroll down below the umbilicus, the separation between the muscles is not as pronounced anymore. It's almost that the muscles come back together. You can kind of see the medial edges of the right rectus muscle and left rectus muscle. They're kissing each other. So what we can tell from this CT scan is that this patient is ideal candidate for robotic abdominal wall reconstruction, because her abdominal wall anatomy has been distorted, not just focally, but throughout her abdominal wall. She has defects. She has a defect right here at the navel area with significant associated diastasis recti, but this diastasis and separation extends all the way up to the chest wall. So the standard approach of going in and just closing this little hole and putting a little mesh here would be the wrong approach for her. She really needs a robotic abdominal wall reconstruction to restore her normal anatomy. So this is a before and after image. On the left side, we have our patient who's laying flat several weeks prior to surgery when I did the initial consultation. On the right side, we have the patient back in my clinic about 4 days after surgery. What we're going to highlight first is really the before and after of the area that was corrected. On the left side, we have the patient presenting, and really the biggest area of separation is going to be around the peri-umbilical area. And this is her stretch marks from carrying 5 babies to term. But as you kind of move up from this area, there's also separation between the rectus abdominis muscles in the epigastric region, probably a little bit less pronounced below the umbilicus. Immediately after surgery, what you note, there is a ridge that has formed, and this ridge is from additional skin that has been stretched over many years, which now protrudes out as the underlying muscles that were separated from each other are brought together and sutured together. So the difference between this surgery and open surgery is generally in open surgery, the additional skin is removed, including, by the way, the scar tissue that you kind of see over here. But in the minimally invasive approach, we don't generally address the skin or the scar tissue until later on, if the patient decides that they want it removed. Our general recommendation initially is to let the repair kind of mature, let the swelling resolve, and if after a year you are unhappy with the cosmetic part of it, meaning that there's additional skin there that you like removed, we would take you back and do a superficial resection of the additional scar tissue or additional skin. In general, most of the skin will shrink, and this ridge that you see in the first few months after surgery gets less and becomes better. Most patients do not end up going back to surgery for a year. The other thing I want to bring your attention to is the periumbilical area. If you look at the after versus the before. Now, in the before area, you can't appreciate it as well here because the patient is laying down, but there is basically an open defect in the fascia here, and if she stands up, you see an additional bulge in the perinaval periumbilical area. This has been corrected by both closing the defect, but also pulling the skin back to create this look to the belly button. Now again, this is just 3 to 4 days after surgery, so there's going to be swelling and additional tissue and scar tissue, so it hasn't matured for its final look, but generally when these heal, it looks really, really nice and very natural belly button that's restored to the patient. So an umbilicoplasty has been performed here. The 3 incisions used are highlighted here laterally, and we have an upper, mid, and lower. This is covered by her pant line as I'm dressing. We generally have a drain that goes through this incision and basically sits in that space that we've dissected to collect the fluid. That drain is removed within about a week after surgery in our clinic. But I wanted to highlight this to you as our initial follow-up pictures. There will be additional follow-up pictures at about 4 to 6 weeks, and then at 6 months and a year, so we can see the progression of changes on the abdominal wall with time. I hope that this video has been informative, and I hope you've kind of gotten an idea of not only how we work up a patient who may be a candidate for abdominal wall reconstruction versus somebody who needs the standard ventral hernia repair. And as we move forward with this patient, we will share videos at 4 weeks, at 4 to 6 weeks, at 6 months, at 1 year, so that you can kind of see the progression of the patient's repair, it maturing. But also at about 1 year after surgery, we generally obtain a post-operative CT scan, and we can look at the before and after CT scan right next to each other to see how we have altered the anatomy and restored it back to its natural form compared to before surgery. And I hope you join us again. If you know somebody who has abdominal wall bulging, diastasis recti, or possible hernia, refer them to us. We will take great care of them. Thank you.